Hi, my name's Kendall. This is our CLC project. I worked with Antonio and Matthew. So let's get started. This is our health risk assessment. We included both the NAS and PAR-Q that will help us to assess if the client is ready and clear for physical activity. This is based on these 7 questions that you see here. If they have answered no to all the questions, then they are okay to move forward with physical activity. But if they answered yes to any of them, which our client didn't, they would move on to another set of questions that we did not include here for space. The next thing we included on this slide was our client history. It's going to help us to determine why dysfunctioning is happening and to help explain why we see certain dysfunction. Certain things that I can point out that would be considered helpful is the occupation. Our client is a student and they are also a babysitter. Students tend to sit for long periods of time, and babysitters are constantly picking up kids and putting them down over and over again, which can cause a lot of back issues. You also have bad posture as a student very often when you're sitting crouched like this at a desk. Yeah, so let's go ahead. So this is our static postural assessment. We viewed from 3 angles: the anterior, lateral, and posterior. We focused on the main kinetic chain checkpoints being the foot and ankle, knee, lumbo-pelvic hip complex, which we're going to go and call LPHC for the rest of the slides, and then the head and cervical spine. This is the picture of the anterior view. We found that there were no abnormalities on the foot and ankle, and the feet were straight and parallel. For the knees, we found that the right knee was not in line with the toes, but the left knee was. You can see it where the line goes through the middle of the body, how the right knee is more overlapping on that line and the left is not. Another dysfunction we found was that the right shoulder was more lower than the left. This could be due to the client's dominant hand being the right. Possible causes of the right knee not being in correct alignment would be from an overactive adductor and or an underactive posterior glute. Both are directly related to assisting in adduction. Possible causes of the tilted shoulder are overactive pectoralis major and minor and or underactive trapezius. And then this is our lateral view. Again, we focused on those main kinetic chain checkpoints being the foot and ankle, knee, lumbo-pelvic hip complex, and the head and cervical spine. For this view, we found that there were no abnormalities on the foot and ankle, but they were in neutral position, so no abnormalities, mostly normal. For the knees, we also found that they were in neutral position, but we did not take the picture from the other side, that side being the side of the knee injury. When we did the client history, for injuries and pain, the client had put that they had ACL tear and ACL surgery on that left knee, but we did not take the picture from that side, so there could have been a dysfunction on the other side, but from this angle, there was not. The dysfunctions that we did find were in the LPHC and the head and cervical spine. There was a slight posterior flexion of the hip and tension in the shoulders and a slightly forward head. Possible causes of the hip tilt not being in correct alignment would be from an overactive latissimus dorsi and or an underactive transverse abdominis. Possible causes of shoulder tension are an overactive sternocleidomastoid and or an underactive rhomboid. Last thing we can notice is that the alignment of the body above the ankles is not aligned with the ankles. There's a slight forward lean, which can be due to the same overactive and underactive muscles that affect the hip tilt. Yeah. So here's the next slide. This is going to be our posterior, our last angle. We found that there were no abnormalities on the foot and ankle, but they were in neutral position, so all good there. For the knees, we found a slight adduction As you can see, the line straight up and down the body, they are inward and more closer towards and a little uneven. Um, the LPHC appeared to be normal and the pelvis is level. Head and cervical spine showed a tilted shoulder. Possible causes of knee adduction would be from an overactive adductor and or underactive glute, like we talked about before. Possible causes of the tilted shoulder are an overactive pectoralis major or minor and or underactive trapezius. You can see on the picture that the line that from the left shoulder to the right, the same kind of depression of the shoulder because of being right dominant, the client. And yeah, now I will hand it over to Matt, who's going to talk to you about our translational movement assessment.
Translational movement assessment overhead squat. There was a couple of normalities, mainly in the foot and ankle. The heels did not rise. The feet did not turn out. That's good. When it comes to her knees, hips, and spine, we found a few abnormalities, including knee valgus, feet flattening, low back arch, and this can be attributed to the kinetic chain and how everything's connected. For example, if you have feet flattening, whether one thing's a cause or it's the product of something else, it helps you figure out what's tight, what's overactive, and what's underactive. You'll see that she has foot flat here in the bottom left, and this will lead into the knee valgus, knees coming inward, the low back arch, as you'll see in the center photo, the low back just really getting torqued down right there. Again, when your feet flatten, knees come in, which is also going to tilt your pelvis forward, anterior pelvic tilt. We're going to go to the single leg squat. Single leg squat is very similar, but also you're able to see any in dominance on one side or imbalances of strength from the left to the right side. So super important for the assessment as a future possible practitioner. Very similar outcomes from this: feet flattening, knee valgus, but you'll also see in this the hip drop due to what we will find in the causes in the next slide. Again, this is a list of overactive and underactive. If we were to be actual practitioners, we would be able to assess every single little bit of this within this CLC project. We only get a couple minutes to do things while doctors, PTs who diagnose such problems, or corrective exercise scientists are able to go through a whole laundry list of assessments, finding which muscles are actually overactive and underactive. These are from the NASM 2013, what you could expect from feet flat, knee valgus, low back arch. To the next slide, single leg squat. Back to the hip drop, you'll see the adductors are going to be probably overactive, and the glutes are going to be underactive, and the quadratus lumborum is going to be underactive as well. Again, you can read through here as well. Very similar muscles that are going to be underactive and overactive when it comes to knee valgus and feet flattening. These are two abnormalities that are different from each assessment.
So during Kyndal's overhead squat assessment, we noticed that she wasn't getting good enough depth. So we decided to assess her range of motion, specifically in hip flexion. Um, so we laid it down on the table, used a goniometer, and performed the test. We found during this test that Kyndal's range of motion was at about 85 degrees, whereas a normal hip flexion range of motion would be about 115 degrees. We can link um, her underactive range of motion to a number of sources. When it comes to overactive muscles, it could be the iliopsoas, the rectus femoris, the TFL, adductors, piriformis. When it comes to underactive muscles, it could be your hip flexors or TFL, rectus femoris, adductors, or the gluteus maximus. This is what we found during the range of motion assessment.
I'm going to do strength assessment. The reason why we picked the gluteus maximus to be assessed for strength, which we actually found that she has little to no, little activation of the gluteus maximus, which is important in all of life. And so, while I applied pressure onto her lower thigh, this dropped the knee really fast. And so that is my portion. I will also go into the references. And here is our references, if it pulls up. There we go. Thank you for watching our CLC project, and I hope you enjoyed it.